Hi guys, welcome back to my channel. My name is Khadija Tadeshola, and in my channel I talk about everything related to women and midwifery. I am extremely sorry for not posting video for a couple of months now. I am so sorry. I'm just been so busy, and also I see that my subscribers are increasing, so I thank you so much for subscribing to my channel. This is the first time of getting across to my channel. In my channel you find information related to women and midwifery, so I will recommend that you subscribe to my channel, especially if you are a midwife that is looking forward to navigating international opportunities, whether in the UK or in any other country. So thank you so much for watching this video, and after you watch this video, if it's something you like, please don't forget to click on the like button, because then this will make YouTube to recommend my videos to more people looking for similar information, and also it will definitely increase my views and my like and the engagement on my channel, and it will be beneficial to me. It will make me to do more videos as well. So thank you so much for doing that. In today's video, I actually want to talk about my experience in delivery suite. If you've been following my channel, so when I get to the UK, after getting my PIN, I started working in the antenatal unit, and the rotation wasn't done as it should be actually. So I spent lots of times in the antenatal unit, then moved to the delivery suite, then I got my baby, then I went on maternity leave. So when I'm back from maternity leave, when I'm back from maternity leave, you all know that I didn't take my full maternity leave, so I didn't take 1 year, so it's less than 1 year I had my baby actually. That's fine. So I go back to delivery suite. Now I'm going to share my experience in delivery suite, and with myself speaking to other midwives in the UK as well. I think most of us are having similar challenges. Okay, so basically, what do you do in the delivery suite? Just a recap. So in delivery suite, you expected to have a delivery lady, a laboring woman actually, and once after the woman had delivered, you expected to transfer the woman to the postnatal ward. Regardless of what form of delivery the lady have, you're supposed to be the person's midwife until she had a baby, except you close your shift, whichever comes earlier. Okay, so now even if your patients end up going to the theater, you are supposed to still be the midwife going to the theater with her. So that's what happened in delivery. So in my trust, in most cases, that's how it is, because they're expected to have a one-on-one care for women in labor. So that's the aim. They try to get a one-on-one care for women in labor. Okay, sometimes as well in delivery, so you have a lady upstairs, you have a lady in antenatal ward that's been waiting for ARM, or that been waiting for oxytocin augmentation or induction of labor. You have lady who have rupture of membrane and GBS positive, and all those kind of things are what you have in delivery suite. Delivery suite is quite risky because a lot of things happens, and whatever happens to that deliver or to that baby is mostly depending on you as a midwife, whether you are in the midwifery-led unit or you are in the consultant unit. The difference between being in midwifery-led unit and consultant unit is basically the fact that the patient mostly be on continuous ECG in consultant unit, and the doctors regularly come for ward round as well. In the midwifery-led unit or birthing unit, in the hospital setting, you still have to escalate to doctors if necessary, but not like a regular thing, and you regularly listen to your fetal heart rate every 15 minutes. Okay, so in delivery suite, you're expected to do, of course we still do the same thing, like 4-hourly VA. If you are in the midwifery, the consultant-led unit, then you're expected to be monitoring the baby via using the CTG and escalate any CTG's concern. As a delivery suite midwife, you must be competent in inter-pattern CTG interpretation. This is because then you will be able to escalate when necessary. You are not expected to escalate later or like too early or something, because the difference with when you escalate what you are not supposed to escalate is the fact that next time, even when you are escalating something that is absolutely important, they might not actually take you serious. So that's the reason you really need to know what you're expected to escalate in delivery suite. So as a delivery suite midwife, you must be competent in intrapartum CTG, that is an interpretation. Okay, I'm sure trusts you do yearly, CTG study day and all of that. So you must really pay attention to those things in uterus and ask questions when necessary. Your band 7 or band 6 experienced midwife are people, your go-to people when you are struggling to interpret CTG. Another thing you're expected to do is your ARM game. So you must be able to be competent in rupture of membrane. So the difference between rupturing of membrane in this country and from back home is the fact that from back home, most cases we ruptured membrane because they are actually, bulging membrane. But in here, rupture membrane is part of the induction of labor process, okay? So sometimes somebody that is 1 centimeter, they will put her in as ARM able. Somebody that is just barely 2 centimeters, they will put her in as ARM able. So you should be able to rupture the membrane. The thing be that if you did not rupture the membrane and you give oxytocin, just oxytocin, it will not work. I have a first line experience. I have experienced it. I was giving oxytocin, it got to the highest dose I could ever eat. This woman was just contracting 2 in 10. And I was like, what is happening? She was even sleeping on Cinto, in this country. Sleeping on Cinto. Then they were like, oh, maybe there was still some forward ARM. Okay, then I did the ARM. Come and see, I had to reduce the oxytocin. Not once, I reduced the oxytocin very well. So if you did not know how to do the ARM, that's one thing you should learn. How will you learn it? So you just have to keep doing it. Okay, so you keep doing it, and now I basically going in there to do ARM. Nobody is. It's your brain. You're using your hand and your brain. You're using your hand and your brain. Okay. So for the ARM, it actually depends. In most cases, if the patient is already on epidural, then it's quite easy because then they are not feeling pain. But if they are not on epidural, you might spend 30 minutes doing ARM. Because then, if the patient wants you to stop, you have to stop. So that makes it quite longer. So that's one of the things you should be competent in. Because then what happens is, if you don't do the ARM very well and you commence into, the woman will not progress well. So you are making the woman to spend longer than necessary in labor just because of your own mistake, okay? And another thing is, sometimes if that happens, and you are in the ship with the same in charge, sometimes they might be looking at you someone kind oh, she doesn't know how to do it and all of that. So you have to be competent enough in that. So you have to try as much as possible to do frequently, so then you might get it wrong a couple of times, but then later you'll be fine. I was like that before as well. Then another thing is be honest. If you think you've not done that, you say, well, I was trying to, but I couldn't reach it. Someone else will come and do it. It's not because you don't know. Sometimes, most cases, if they are on, oxytocin, if they are not on epidural, then it's very painful. They might not cooperate as well. Sometimes, depends on the person's body structure. It might be very, very difficult. Another time depends on the dilatation and the state of the cervix. Sometimes, if the cervix is very, very firm, then, in fact, you might want to regret, why did I come to midwifery? Sometimes, with those kind of biggies. So it's not a big deal if you can't do the ARM. Just tell your midwife that you have not done it. So don't say I have done it when you've not done it, because then if you do like that, the woman go into labor, the woman get oxytocin and it wouldn't work. So after 4 hours and the thing is, we start counting time, so we just adding time that is unnecessary for the woman. So try as much as possible to do it more frequent than it. Another thing in this read then is the station, positioning, knowing the position. So from back home, we don't really take vaginal examination, knowing the position via vaginal examination very serious. We usually do, abdominal palpation and just say, okay, it's ROA and all of that. But the thing is, they want to know whether it's right occipital anterior, left occipital anterior, or sorry, they want to know whether it's occipital anterior, occipital posterior, or transverse. That's the most important thing they want to know here. Okay, you might not decide is it right or left, but then you want to know importantly whether it's OA, OP, or OT position. This is very important because this then affects the decision of the managing consultant. Okay, if it's OA and she's not progressing, or maybe she's 6 centimeters, 6 centimeters, or they might still want to give her a little bit of time, like because it's OA. If it is OP, then if she's 6 centimeters, she's 6 centimeters. I know, okay, maybe my position, even with the oxytocin, it might not really, so there will be a little or low threshold for intervention. But if it is OA, you might be like, okay, maybe she's not contracting well. Try to pick the contraction very well. Try and change the position. Try allow her to mobilize. Try emptying the bladder, because there could be a lot of things that have been causing it. But if it is like OP position, maybe like, okay, even after doing that, there may be little or no, different. Also, the pain might be more intense because of the back, so they might want to like, okay, the woman, you may also help the woman to make a decision whether she wants to go for epidural or she wants to continue without having any, epidural or using the gas or take any other form of pain relief. The occipital transverse position, then they might want to use, okay, so in my trust now they try to use the peanut balls that help to in the positioning. It helps to help the baby to rotate. They might want to put the baby in some the mom in a particular position just to allow the baby to rotate. So it's very important to know the position of the baby, and that is what they know vaginally. And please, if you are a midwife in the UK and you were struggling at one point, maybe you know it now, you were struggling at one point to locate the position during vaginal examination, please tell us what you do. And what you do is not part of what I'm saying now, so please tell us what you do in the comment section so that I myself I can learn. I can tell you I've only got it for a couple of times, to be sincere, and I just think that it's worth sharing to you. So shout out to Lara, a midwife in Framley. She was the one that told me, that explained this to me, because she was, she was finding it difficult as well when she newly came in, but she's been band 6 for a couple of years now, and unlike me that I've gone to maternity leave, I've left the practice for a while to come back. She's always been in practice, so I can say that she's more experienced than me as in midwifery in the UK. I don't know whenever she compare or wherever, but I know that she's more experienced than me when it comes to midwifery practice in the UK. So shout out to her. And yeah, she told me that, okay, so when you go in, try to locate the posterior fontanelle. Okay, if it's very easy for you to locate the posterior fontanelle, then it means that the position is OA. Okay, you will not be left to knowing whether it is right OA or left OA, or is transverse, sorry, whether it's right OA or left OA. If it's easy for you to locate the posterior fontanelle. Locating the posterior fontanelle means that if you go in and you can really easily feel the posterior fontanelle, then it means that the baby is like that. Okay, so the head is well first. So then it is occipital anterior. Okay, but if you go in and it's not easy for you to locate the posterior fontanelle, like you can't easily rotate the posterior fontanelle, okay, but you still find it. So it may be that the head is not just well flexed, it's still, maybe like OA. But if you can't feel the posterior fontanelles, like it's very, very difficult for you to, like you can't feel the posterior fontanelle at all, then it is an OP position. Because if the head is like that, or here that you're feeling, you are not seeing the posterior fontanelle, maybe this place is already done, you're just feeling here, so then it makes it an OP position. Okay, so another thing I can do is I will put the picture. I will have the picture to this, to this video, so that then you can understand much better. So what happened is I snap a pictures, I can put it up there. I send a picture of those things on my phone. Some trusts have it on their MABU unit, so you can just check it, snap it, and once you do your VE, put the thing in your brain. Whenever you feel the posterior fontanelle, put it in your brain, look at the pictures, and you'll be able to determine what the position is. Another thing is, I actually saw one of the midwives, the senior midwife. She actually snapped, but she actually printed the stuffs that can hide the card, or she printed at the back, and she added it to her name tag. I was like, oh. So once you do VE, you just open it, and just, if I can see that kind of thing, it would be nice. That would be great to do it as well. So then it will be very, very helpful. So when else you go to that VE, another thing is, if they are not in epidural again, you might not be able to find the position, because it's quite uncomfortable, and you have to keep reassuring that. And if she's not cooperating, if she asks you to stop, there's really nothing you can do. So you can just put position cannot be determined. Yeah, have I gotten the position before? Yes, I've gotten this before. I got it. It was actually OT position, and the doctor came an hour earlier after to check, and he was like, yeah, it's OT. I was so happy, because then I felt the posterior fontanelle this way, this side, so you can tell that it is a transverse position. So the patient was just looking like that, so this was like this, so it is a transverse position. So if you anywhere you get that posterior fontanelle, then you'll be able to determine what the position is. And it was very, very, very helpful, and it was right when I did it. So I will encourage you to try it, and if you try it, if it worked for you, please come back to this video and to say it in the comment section. So thank you so much for watching this video, and I will see you in my next video. And don't forget, if you have not subscribed to this channel, please, this is the right time for you to subscribe to my channel. And to my 3,000 subscribers, I say is I'm blowing you guys a kiss. Thank you so much for watching my videos. Bye.